Mr. Chairman, ladies and gentlemen, good afternoon. I bring you greetings from the American Society of Nuclear Cardiology, and we feel very privileged to be part of this excellent conference. And I personally want to say how honored I am to be invited to speak. This is my first visit to South America and my first visit to Bogota. It's a beautiful country, we're very friendly people. Yo estoy feliz, muchas gracias. And now it is my job to keep you awake after that heavy meal. So this is a chapter that I wrote in Dr. Garcia's textbook of nuclear cardiology. And it is one scheme for the evaluation of patients who present with heart failure. And when you see these patients, there are certain things that you want to know related to systolic and diastolic function. And one of the most important steps in the evaluation of new onset heart failure is to see whether patients have extensive coronary artery disease, especially patients who have low ejection fraction, because here is an opportunity to actually cure heart failure in some selected patients. So we try to figure out if they have extensive ischemia and viability, and if they have ischemia and viability, we traditionally revascularize them. For patients who do not have a lot of viability, and in the large category of patients with non-ischemic cardiomyopathy, there are some specific applications of nuclear cardiology. But most of these patients are left with guideline-based optimal medical therapy, ICDs and CRTs, and for a small proportion of patients, advanced therapies like LVAD and heart transplantation. And I was speaking to some of your colleagues, and I learned that there's a lot of organ transplantation happening in Colombia. So these are the situations where nuclear cardiology is potentially useful. And there are many steps along the process where different nuclear cardiology techniques can be used to advantage to patient care. Now, it's a very large topic, and so I will today concentrate on a few clinically challenging situations where nuclear cardiology has been found to be very, very effective, and in some cases has transformed heart failure therapy. The first of these is infiltrative cardiomyopathies, and I take the example of sarcoid. And here is an example of a PET scan with FDG showing focal infiltrates that take up FDG PET. As of today, this is the only technique that distinguishes between quiescent and active sarcoidosis. This is an extremely challenging clinical situation because when you make the diagnosis of active sarcoidosis, you give patients very high doses of steroids. And almost invariably, they have side effects from steroids. So the decision to treat cardiac sarcoidosis actively is a major one, and it's a big clinical challenge. And PET helps there. You see FDG uptake in areas of active inflammation. So you can do a perfusion scan, you can do echo, you can do MRI, and these will show you infiltrates, but only PET will tell you which of these are actually active. And what is more, there's evolving data in this field to show that if you do serial PET scans, and you show that the treatment is effective in suppressing inflammation, then that is associated with an improvement in cardiac function over time. Very powerful and very compelling data. But to perform a good PET scan for sarcoidosis, we have to have some knowledge of myocardial metabolic modulation. And you know that the normal myocardium can use either free fatty acids or glucose for metabolism. So in a patient who's fasted, the myocardium preferentially uses free fatty acids for metabolism. In the contrary, if you glucose load the patient or in the postprandial state, the myocardium will preferentially use glucose. This is really important to remember when you use FDG imaging of the myocardium. However, ischemic myocardium and inflamed myocardium, both in the fasting state and in the postprandial state, will preferentially use glucose. And we use this knowledge in executing the various protocols for viability, sarcoidosis, and infection imaging. So here are some examples. Here's a rest perfusion study, and this could be N13 ammonia, it could be a SPECT study with technetium. And here is a rest FDG PET scan, and this is a patient who's fasted. And in this fasted state, in the lateral wall, you see that perfusion is normal. So this is normal myocardium. And normal myocardium in a properly fasted patient does not take up FDG. In contrast, in the apex, you see a perfusion abnormality. This could either be resting ischemia, or it could be an infiltration. But in the fasting state, that area takes up FDG, so something is wrong there. Reduced perfusion, FDG uptake. So either ischemia or inflammation in the fasting state will take up FDG. Now, when you do inflammation imaging, such as in sarcoidosis, you have an area of interest, and you want only that area of interest to take up FDG if it is inflamed. So these studies, infection and inflammation, should be done under good fasting conditions. In contrast, so there is the normal myocardium, and there's this ischemia or inflammation. Now, it also follows that when you're looking for inflammation, you have to make sure that the patient does not have coronary artery disease and ischemia, because ischemia can confound interpretation of inflammation. Now, in the postprandial state here is a patient with reduced perfusion, and with glucose loading, that area takes up FDG. So this again could be inflammation, or it could be ischemia, but when you test for ischemia, you want to give the myocardium every chance of taking up glucose. You want to glucose load, put the patient in a postprandial state, give insulin, and it doesn't matter if the rest of the myocardium takes up FDG. All you want to know is whether the ischemic area takes up FDG. So this is why the inflammation infection studies are done under the fasting state, and the ischemia and viability studies are done under glucose loading, and you will hear more in detail about these protocols tomorrow. So that's ischemia, and that's normal. So these are the protocols that are used for ischemia and viability studies versus inflammation, and I will not go into the details of this because tomorrow you have specific talks addressing these topics. But if you have a good patient prep, these are the sort of studies that you can get. Here is a patient with a prosthetic valve. The echo showed some suspicion of paravalvular abscesses, and you can see a lot of uptake of FDG. Now, remember that FDG is non-specific inflammation. There's lots of studies looking at other things like dotatate to see if we can get more specific markers of inflammation in studies such as sarcoidosis. And here, in addition, is another finding with total body imaging of an infected embolus to the great toe. Now, let's change tack and talk about another area where imaging has become very, very useful. And this is cardiac amyloidosis, and I want to start with a case. And this is a 51-year-old male. He's a real patient who I saw who presented with new-onset atrial fibrillation and severe heart failure. Now, his father had died of a polyneuropathy, and you know that hereditary amyloidosis can present either as a polyneuropathy or as a cardiomyopathy, and his father had died 10 years ago with progressive debilitating polyneuropathy. We knew that he had a VAL13 mutation, which is one of the most common forms of hereditary amyloidosis, and it presents either as familial amyloid polyneuropathy or cardiomyopathy, but we knew he had a VAL13 mutation. So this is what this gentleman's ECG showed. He had atrial fibrillation, it had a left bundle branch block, so something was not right. And in the morning, he had an echo that showed some typical features of amyloidosis. Thick ventricles, large atria. You don't see this well here. Interatrial septum is thickened, and there's a small pericardial effusion. So if you see unexplained ventricular hypertrophy, the tip-off to infiltrative cardiomyopathy is the presence of a thickened interatrial septum and a pericardial effusion. When you see these two things, you should think of amyloidosis. So I went back to the patient and I said, did your father have cardiac involvement in addition to the peripheral neuropathy? And he said, you know, Dr. Soman, we don't know. He had this very sophisticated diagnosis of a VAL13 mutation, but he didn't want a cardiac biopsy. Because 10 years ago, the only way to diagnose cardiac amyloidosis was with a biopsy. And he didn't want that and so we didn't know whether he had cardiac involvement from his amyloidosis. Fast forward just a decade. So this man is admitted in the night, he has an echo in the morning, and with very little fanfare later that day, he goes to the nuclear lab, gets a technetium pyrophosphate scan, which was avidly positive. We make a diagnosis of cardiac ATTR amyloidosis, and the diagnostic confidence is 100%. So if you want an example of how imaging has transformed a field, cardiac amyloidosis is a great example. So this is how the pyrophosphate scan looks like. It's a bone scan, as you all know. In this patient, there is absolutely no cardiac uptake of pyrophosphate. This is a scan that is negative for cardiac ATTR amyloidosis. And here's a patient with very avid and diffuse uptake in the myocardium of pyrophosphate. And this is 100% diagnostic certainty for ATTR cardiac amyloidosis. This is the corresponding SPECT scan showing that the uptake is in the myocardium and it is not in the cavity. The American Society of Nuclear Cardiology has standardized procedures, and this is available. Now, many of you in the audience know that pyrophosphate is not a new tracer. Years ago, it was tested for its ability to diagnose cardiac amyloidosis, and early studies suggested that the sensitivity was not high enough for it to be used as a screening tool. And this is because we didn't quite understand how it works. Cardiac amyloidosis, as you know, can exist in two forms. There is primary AL amyloidosis, which is like a blood cancer. It's a plasma cell dyscrasia. There's unregulated proliferation of plasma cells, production of huge amounts of light chain, immunoglobulin fractions, and these form amyloid clumps, and it becomes a systemic disease. The other type is the transthyretin amyloidosis. Transthyretin, carrier of thyroxine and retinol. It's a normal protein. And one of the big mysteries in medicine is why a completely normal protein in some people as we age forms amyloid and produces a disease that has a great degree of tropism for the heart. We now know that it gets deposited in some other tissues also, but it is mostly a cardiac disease, and we don't know why. And then you have the familial forms, which is a mutated gene, and the gene mutation makes the protein unstable, and it deposits in the peripheral nerves and in the heart. These are the two areas that are mostly involved. Now, PYP is positive only in ATTR amyloidosis, and we didn't know this. And early studies included both AL amyloidosis and ATTR amyloidosis, and that's why the early studies suggested that the sensitivity was low. The high diagnostic accuracy of PYP was recently established by this study, aptly termed a non-biopsy diagnosis of cardiac transthyretin amyloidosis. A relatively large population of more than 1,000 patients suspected cardiac amyloidosis, showing a sensitivity of more than 90% and a specificity of ATTR, however, with one caveat, that the serum studies for AL amyloidosis have to be negative. And this is because a small number of patients with AL amyloidosis will show mild uptake of ATTR. So to be absolutely sure, these studies have always to be done with serum testing for AL amyloidosis. In my lab, if you refer a patient to my lab for PYP scanning, they will automatically get free light chains and serum IFE done. So the high diagnostic specificity is in the context of negative serum studies for amyloidosis. Now, the pyrophosphate scan, I mentioned that it is useful to do SPECT scans to make sure that the tracer is actually in the myocardium and not in the cavity. Here is an example of a planar image that seems to be positive, but if you look at the SPECT scans, they look like RVGs because the tracer is mostly in the cavity. And indeed, when we repeated the study 3 hours later, the study is negative. And so, as I mentioned, PYP has really transformed the field of cardiac amyloidosis. We can now make a confirmatory diagnosis without a biopsy, and in my institution, for example, we've had about a 30% positivity rate of PYPs, and this has led to the establishment of a multidisciplinary amyloid center, simply based on our experience with imaging. And with the ability to make a diagnosis without cardiac biopsy, now we recognize that the prevalence of this disease is much higher than we ever thought. In fact, it appears that about 15% of elderly patients with heart failure and preserved ejection fraction with thick ventricles have cardiac ATTR amyloidosis. Now, this is a huge number. In the United States, we make about 600,000 new diagnoses of heart failure every year. And about 50% of these patients have heart failure with preserved ejection fraction. So even if 20% of these patients have cardiac amyloidosis, it is a much, much larger number than we ever thought. We also now know, and this is our experience in our TAVR center, transcutaneous aortic valve implantation, about 15% of patients with this very intriguing condition of paradoxical low gradient severe aortic stenosis. They have tight aortic valves, but the gradient is low despite the fact that LV function appears normal, and about 15% of these patients turn out to have amyloidosis, and it's created a great dilemma of what do we do? Do we give them new valves, and so on and so forth. This is one of the studies from Spain that established the high incidence of transthyretin amyloidosis and heart failure. It's also allowed us early screening of families, so if a patient comes with proven ATTR amyloidosis, in the olden days you had to do a biopsy to identify the disease before echo became positive. Today we have a non-invasive means of doing that. And most importantly, it has facilitated recruitment into clinical trials. And as you probably know, there are a number of very interesting drugs, at least 2 of which have been submitted for FDA approval. So by the end of this year, we hope that there will be 2 drugs that can be used to treat ATTR cardiac amyloidosis. And so there is therapeutic hope in this area where there was nothing that we could do for these patients. Now, there are many other things that can be used, other imaging modalities that can be used. There are 2 PET agents, C11-PIP and F18-fluorobeta-PIR. Both were agents developed for amyloid imaging, and we now know that they are both picked up by AL amyloidosis as well as ATTR amyloidosis. It's interesting that the 2 bone agents, one SPECT and one PET, are only picked up by ATTR amyloidosis, and it's tempting to speculate that this is something to do with calcium phosphate metabolism. We've never been able to show a difference in the amount of calcium in AL fibrils and ATTR fibrils. So it's most likely something to do with the structural conformation and binding of PYP to ATTR and not to AL. I don't have time to go through all the imaging modalities, but both echo and CMR can be used. There's a peculiar late gadolinium enhancement pattern of CMR known as the inability to null the myocardium, which is supposed to be quite specific for cardiac amyloidosis, and strain imaging with echo is becoming increasingly popular. These are some data from our lab, and I want to say that it has not been peer-reviewed for publications actually being peer-reviewed now, but we presented it in abstract form. And we find that even strain imaging in echo, we were not able to reproduce the very high sensitivity that was reported in the original inaugural paper from Cleveland Clinic. And with MR, we found that it has a very high sensitivity, but the specificity is lower than PYP. So everything that looks like amyloid in CMR is not really amyloidosis. So that's a quick summary of 2 infiltrative cardiomyopathies. I want to show you a few slides about another very challenging situation in heart failure, and that is allograft vasculopathy after heart transplantation. I know that you in this hospital did 85 cardiac transplants this year, which is a big number, and this is a really challenging aspect of post-transplant care. There's an incidence of about 10 to 50%, depending on what source you look at, 1 to 5 years after transplantation. It's quite interesting in that the host usually does not have risk factors for CAD. And in fact, the host's vascular system, if you look at the carotids, if you look at the abdominal aorta and the peripheral vessels, they're not usually involved with atherosclerosis. It's only the heart, the recipient heart, that is involved, and therefore this is thought to be immune-mediated. What's important is that the prognosis is quite bad, and there's only a 40% 1-year survival after an ischemic event from allograft vasculopathy. Now, clinical challenge here is because the ischemia is usually silent. Remember, the transplanted heart is denervated and patients don't have angina. So today, it's standard practice in the United States that after heart transplantation, patients will undergo periodic coronary angiography, sometimes with a biopsy, to identify and treat allograft vasculopathy early. So this is a really invasive approach to the early diagnosis of allograft vasculopathy. The second thing is that the disease is usually affecting the small vessels, and it's very difficult to diagnose with angiography. Here are examples of epicardial coronary angiograms that look relatively normal, yet both of these patients are significantly affected by allograft vasculopathy. So the first use of PET myocardial flow reserve evaluation in transplant vasculopathy came from Rob Beanland's group and showed some very, very interesting data in that if the myocardial flow reserve was preserved, these patients had an excellent prognosis for 2 to 3 years. So here is a great example of how imaging can help in a very challenging clinical situation and maybe substitute a non-invasive method for what is standard now, and that is angiography and periodic biopsy. More recently, they published even more quantitative data with IVUS, intravascular ultrasound correlations, and they showed that there can be actually cutoffs in the myocardial flow reserve and the peak stress myocardial blood flows, again showing that if these values are normal, cardiac allograft vasculopathy is extremely unlikely. So this is a very exciting field, and I think like with amyloidosis, if we develop imaging techniques to address pressing clinical needs, the technique just takes off. I mean, look at cardiac amyloidosis. It's a very cheap tracer. It's been available. Nobody is promoting it. In my lab, we get referrals for 2 to 5 PYP scans every day. That is the magnitude. So again, I think here is a clinical challenge, and when we develop a technique to address a clinical challenge, it is automatically utilized. Now, this is not the first time that perfusion imaging has been looked at in this area. Years ago, this study showing a normal SPECT, normal LV function, normal perfusion, showed that there's good prognostic data in patients with allograft vasculopathy in the intermediate term. But I think the data with PET are much stronger. And finally, I want to talk about one of the most difficult aspects of imaging, and that is RV assessment in heart failure patients. Now, as you know, the RV is really difficult to image. One of the problems is that it's not a geometrical shape. Whether you do MR or whether you do echo, for example, in the left ventricle, whether you use the Simpson's method or some other technique to assess LV ejection fraction, LV volumes and ejection fraction, you have to make some geometrical assumptions. The structure of the RV is so irregular and heterogeneous that you cannot make any geometrical assumptions. And therefore, count-based approaches, such as radionuclide ventriculography, may be particularly suited for RV imaging. It's not well seen on gated SPECT, as you can see, and we all know that with the traditional two-dimensional radionuclide ventriculography, it's really difficult to separate the right atrium from behind the right ventricle. And this is a really important limitation for the quantitative assessment of RV function by radionuclide ventriculography. It's not easy with MR either, although MR is now considered the gold standard. Here is an example from my colleagues. This shows you the approach, the current approach to RV ejection fraction assessment. You have to reduce the RV to multiple two-dimensional slices and draw the endocardial borders in each of these slices and manually compute the right ventricular ejection fraction. And in any approach where there is a lot of operator input, there is bound to be lack of precision. So we have been looking at gated blood pool specs for RV ejection fraction. And here is a completely automated quantitative technique where you can visualize and quantitate RV volumes and ejection fraction. Now, I have to tell you that the RV volumes, we don't get consistently reliable values on the RV volumes, but we have found that quantitative assessment of ejection fraction is quite reproducible with gated blood pool SPECT. So here is an example of a gated blood pool SPECT where the RV function is completely normal. Here is another example of a patient in whom the RV function was considered normal with echocardiography. Now, those of you who do echo know that RV function is estimated by TAPSE, or the tricuspid annular plane excursion. And here you can see that the base of the RV is moving quite well, and this RV was reported as normal. But look at this RV on the gated blood pool scan. Indeed, TAPSE is normal, and the base of the RV is functioning quite well, but there is significant regional dysfunction in the free wall and apex, which you cannot appreciate on the two-dimensional echocardiogram, and the RV ejection fraction here was 35%. So in many of these studies, we would take, we go to the operating room when these patients underwent transplant or LVAD assessments, and in quite a few number of patients, we could see that the free wall was exactly as we saw on the gated blood pool scan. What we saw before the patient went on cardiopulmonary bypass was exactly what you saw on the gated blood pool SPECT. So here are some examples of regional function on RV blood pool evaluation. So this is a completely normal RV. Here is a patient with global RV systolic dysfunction. The next one is, you can see that the base of the heart is moving well, but the free wall is hypokinetic, and so on and so forth. So what we found here, and what we find extremely useful, is that in addition to global RV function, we were able to determine regional RV function. And what is more, in a small number of patients, looking at 71 of our initial patients, now we have a cohort of more than 200 patients, and these are patients who underwent left ventricular assist device implantation. This is a really challenging clinical situation because based on the function of the RV, patients either get only left ventricular assistance or biventricular assistance. And outcome is really, really dependent on what the RV function looks like. And in this small number of patients, we see that RV free wall hypokinesis is associated with poor outcome and RV failure after LVAD implantation. We didn't quite understand why this was so, but I think there is a good physiological explanation. When you put a left ventricular assist device in the LV and you decompress the LV, you find that the septum then becomes immobile, right? And RV function is then completely dependent on free wall function. Here is an example of how this happens. You see this is a very severely dysfunctional left ventricle. It's a fairly dysfunctional right ventricle. When you turn on the LVAD, the septum becomes completely plastered. So if you go into LVAD implantation with a hypokinesis of the right ventricular free wall, that predicts poor outcome. And today, in our institution, we are a big transplant center. Every patient who has an LVAD has a gated blood pool scan before LVAD implantation. It's also very good for serial evaluations. Here is that patient I showed you, where the base of the heart is functioning well, the free wall is not functioning well. This was thought to be a normal RV on echocardiogram. This patient had a left ventricular assist device, and then 1 year later, you see that the left ventricle is now decompressed, but with the cardiac output increasing, with the LVAD, now the RV is subjected to a huge volume, didn't like it at all, and the RV is dilated greatly after the implantation. So I think this is an evolving area, but again, a possible good application of radionuclide imaging in a very challenging clinical situation. We are trying to quantify RV regional function, looking at value of RV dysynchrony in these patients, and we do see some differences in standard measures of dysynchrony in patients who do well and who don't do well. Again, this is very preliminary data, only presented in abstract form, but this is an ongoing study. So I've tried to show you a snapshot of a few situations where radionuclide imaging is very useful in heart failure patients, and I will leave you where I started. At every stage in the evaluation of a heart failure patient, there could be a useful role for radionuclide imaging. And before I finish, I want to extend to you all a personal invitation to ASNIC 2018 on behalf of myself and Kathy Flood, our CEO who's sitting there. Please do come to San Francisco. Thank you very much.